now let's talk about, all these trials that have come around, the ARANOTE, ARASENS, these 3 trials. So darolutamide now is approved based on the ARANOTE trial. And we discussed that, you'll see the toxicity profile. And has this really changed your practice if, let's say, you were an apalutamide or enzalutamide person or abiraterone person? Are you now switching everybody to darolutamide, or you've not really made any changes to your practice if you were going to use a doublet? Chris?
Yeah, so obviously having that ability to use as a doublet is very important because, previously if someone was on apixaban for their atrial fibrillation, right, we could not give apalutamide or enzalutamide, so they're committing them to abiraterone, which, for other reasons is troublesome sometimes from being able to take it. So it opens that door up. I think it has, my darolutamide usage in doublet has increased. The one thing, it's a more recent trial, so the overall survival data has not matured yet. So I think apalutamide still has a place, but certainly I'm using more darolutamide than I had previously done.
How do you think the compliance is for your patients? I mean, it is 4 pills a day versus 1 pill of apalutamide a day.
Yeah, I'm not sure, I guess, but.
I mean, they tell us they're taking them.
Yeah.
Right, just like the PARP inhibitors.
Yeah.
But the nice thing is when you show them this toxicity profile, I show them the data in the study and look, this many people have an adverse event, but look at the placebo arm. All these people had the adverse event, and it's really reassuring to them how well tolerated that drug is.
I think it's nice the more options we have, I think ultimately the patients benefit.
Yeah.
We do have to highlight, as Chris mentioned, that we don't yet have any survival data for it in terms of an OS benefit, and the other ones have clear OS benefits. I don't think it's going to stop people from using it. I think many people sort of fell in love with the drug in the M0 CRPC setting, where it became kind of a go-to because of the favorable toxicity. I know that people were using it in the CSPC setting before it was approved by ordering the triplet and just not giving chemo.
Yeah.
And I think we have to ask, what is it, even in the absence of any OS yet, that will set it apart in terms of being able to use it? And that will be the toxicity profile and the ability not to have to be as concerned with concomitant medications. Right? So each of these has a role. There's obviously a benefit and a role for darolutamide. I mentioned earlier that patient who was sort of highly concerned about toxicity, so it becomes a no-brainer.
Yeah.
But the average patient, I don't think that suddenly everyone's going to shift over to darolutamide. I think anytime there's a new drug on the market, it takes time to figure out what the right place is for that specific medication.
Yeah. And I think with the question about overall survival, it's going to become harder and harder with that bar of so many subsequent therapies now being available for our patients.
I think one of the things that I've found, which unfortunately is a reality of what we do, is insurance coverage. Yes. So some of it is dictated on which one insurance is going to cover and how much it's going to cost.
Yeah.
So I found, fortunately, darolutamide I've been using a little bit more, so I found a little bit more easier to get at least financial assistance for.
And you'll be
versus some of the older ones.
surprised, like insurance decline it. And you don't know why they approve one and decline one.
Yeah, that's something we really can't figure out, It's above our pay grade for sure. So let me ask you this. We don't want to do cross-trial comparison, but with the ARASENS trial, which is darolutamide with ADT and docetaxel, versus the PEACE-1 trial, do you find okay, my patient belongs, more represented in this trial, I should use abiraterone and docetaxel versus darolutamide and docetaxel? Like in my practice, I have used a lot of abiraterone and docetaxel. I find it, they're getting steroid anyway for the docetaxel, so I really don't mind giving abiraterone, especially for those. Actually now I think I have a good cohort of a lot of these homeless patients who just come after repeated ER visits, and we find widely metastatic disease. So it's just easier not to deal with insurance and, start on abiraterone and get them that aid and stuff. So they've done well. But in your mind, are you still going to be 50-50 between abiraterone and plus chemo, or darolutamide is the...
Yeah, for triplet, my go-to is the ARASENS. I mean, that trial was designed to test triplet versus chemotherapy. I mean, obviously, PEACE-1 had, multiple arms. It was a very complicated trial. And having the no steroid, I don't necessarily always give steroid with the hormone-sensitive setting with the docetaxel. So I tend to use more darolutamide.
I agree. I think even though I mentioned that, as a doublet, there are specific places for each one, in the triplet setting, I lean much more towards darolutamide because I know that they're going to be dealing with toxicity from chemo. So anything I can do to minimize any sort of problems. Even the electrolyte abnormalities that you can see with abiraterone can be difficult to manage in a patient who's on chemo and might have decreased PO intake or some nausea and vomiting or diarrhea, et cetera. So the triplet is a place where where I use it the most. And then in the doublet setting, a little bit more nuanced.
So ever since ARASENS, I'm sensing most of you have switched to the darolutamide before it was
Especially
not enough.
docetaxel can be toxic. in
Yeah.
certain patients.
And most of these people have other medical comorbidities, so the blood pressure issues. For whatever reason, we always get people. My
Diabetes.
blood pressure is great. It's 170.
Yeah,
Well, this is the
feel fine
reality.
with it.
Yeah, that
and the cardiac issues
Yep.
and yeah.
right. Sometimes the trial patients don't reflect necessarily the real world
Yeah.
data, and especially in the community. So I think that I agree with less toxicity is better if I'm going to get the same benefit.
And then now let's switch gears towards the bone-directed therapies. For the piece 3, the enzalutamide versus enzalutamide radium. What are do you think it's still applicable in our patient population? This trial was mainly done ex-US where, maybe other therapies are not available. So how many of you are still using radium a lot? Anybody?
I have not.
So interestingly, I had a patient that I got update. He's gone through, lutetium, chemotherapy, both, and I have him on Enza plus radium. I think that was a surprising result from that cooperative group trial, but it was a pleasant surprise showing a fairly significant survival benefit. So look, I don't know where it's going to fit in the whole sequence of things, but it's a nice tool to have, especially if someone has, because we used to think radium only if you have bone-only disease. But now if you have some lymph nodes, the Enza can perhaps take care of that along with the radium, and it's well tolerated in my handful of patients I've given it
Yeah,
to.
I use radium quite a bit too when I've exhausted other things. And in lymph node only you can because it's not visceral mets, but with this Enza addition. So you have experience with this combination. Anyone else?
I haven't used it, the combination,
Okay,
but I've used it before.
yeah.
I use radium in clinical practice. To me, the benefit in the CRPC setting for an OS has to be OS and has to be legit in order to give two therapies together, which can add toxicity. Because if there's only PFS benefits, you can just give them sequentially.
Yeah.
I tend to give them sequentially. Often also patients have gotten another novel hormonal agent that was, an AR inhibitor already early on. They may have already gotten 2 of them. I'm trying to figure out where radium goes in the spectrum,
Combination, yeah.
even as a monotherapy. I used to think before we had lutetium and before we had, PARP inhibitors, before we had all these agents, the general consensus was to give it early. Low burden of bone disease, low PSA. You may not see a PSA change, so if the PSA is low anyhow, you feel comforted. I think many are moving now to still use it, but to reserve it for a little bit later on in the disease course after patients have gotten the benefits from, let's say docetaxel and lutetium and maybe another mechanism of a novel hormonal agent.
Yeah. And, my practice also, I don't worry about the PSA while on radium, so don't even check it. So it looks like do you guys have access to radium at your facility?
Nope, we have to refer.
We used to, but it stopped. It used to be at our
Yeah, I thought-
hospital, but
Okay.
not anymore.
Further.
They're trying to get it back, both lutetium and radium.
Did you have access to lutetium before?
No,
No, not yet.
not
Okay.
yet.
I guess the isolated rooms is a problem with that one.